Okay, welcome to the Krause Institute Mood and Anxiety Disorders course. Mood and anxiety disorders are really, really common, and one of the things that happens is people don't really understand the pathophysiology. They simplify depression being something related to a single neurotransmitter. They think that things like anxiety may be just an isolated nutrient deficiency, and it's really much more complex. And if you really look at the data, and I'm going to share the data with you, the current model for using antidepressants are failing. They're not really making a big difference with patients, especially in long term. And we have many people that are walking into the healthcare arena with these mood and anxiety disorders and bipolar disorders without really knowing what to do. And there's a huge gap between what's been published in the literature and what's being used today that we really want to fill. And when you really look at the pathophysiology of mood and anxiety disorders, you're going to realize, as most of you already know, it absolutely requires an individualized and personalized approach. So generalizability, where everyone just gets one type of antidepressant and maybe four or five different classes and switches from one to another, isn't really where it's at. And ultimately, when you see people that have chronic mood disorders, there's something unhealthy with their brain. There's something wrong with their limbic system. Maybe it's neurodegeneration, maybe it's demyelination, maybe it's microvascular disease. So we want to go through the process clinically and help you evaluate those. And then we're going to go through this outline here. So we're going to go into an introduction first, just to review the basic concepts of mood and anxiety disorders. Then we're going to go take a deep dive into the neurology, neurochemistry, neuroimmunology of mood disorders. And then we're going to talk about the physiological web, how different systems in the body all integrate and have an impact on the limbic system. And then we'll start to get into what's been published on in the scientific literature about nutraceuticals that impact brain neurochemistry. Then we'll do a dive into what's been published in literature with environmental, dietary, and lifestyle factors that impact mood disorders. And then most importantly was to then go into a step-by-step how to actually evaluate mood disorders, how to really create a treatment program. And then I'm going to share with you some real case studies of patients with mood disorders and how we evaluated them, how we worked them through the process. So for the first part, the introduction, my academic goal is to review various types of mood disorders presented in clinical practice. So we'll break down the various types and what some of the mechanisms are that cause those types of mood disorders. And the clinical goal is to review the diagnostic criteria for mood disorders, understand the clinical limitations and strengths of conventional alternative medicine clinical models. Now, let's start with this. What's the definition of mood disorders? Well, mood disorders are characterized by significant changes in mood that have a negative impact on daily life. Or you can think of it as there's some loss of function, right? We all have different changes of our mood. That's normal. But when you get someone who has depression, just because, they just have a bad day, they don't feel that well, that's totally different than someone who has depression and can't get out of bed and function and go to work and do things. And that's what we're really focusing on. The types of mood disorders that have direct impact on the ability to function properly. Now, when you look at mood disorders, you can classify them as depressive mood disorders, and you see a subcategory of different ones. We'll go through those. Then when we look at anxiety, you can see a subset of different anxiety disorders, and then we'll get into bipolar disorder. Now, if you look at the literature and look at how common these things are, mood disorders, particularly major depression, have been estimated to be the fourth major cause of disability worldwide, and may become the second only to cardiovascular disease in the next 2 decades. So the fourth major cause of disability worldwide. That is very, very significant. And I think you're going to see why as we go through the material. And the simple answer is because what's actually taking place in a mood disorder is not being accounted for when it comes to an appropriate treatment model. Now, when you look at data that was published by Our World in Data in the United States, you can look at different types of mood disorders, and you can see that 6.16% of the population fit the diagnostic criteria for anxiety disorder. Not that they have anxiety here and there, but they have anxiety for months, and it's actually impacting the quality of life and the ability to function. And then 4.7% of the population have depression. So you can see it's very, very, very significant. And when you look at the disease percentages of mood and anxiety disorders in Europe, you can see it's pretty similar. And if you look at all neurological diseases, it's 4.7%. And you look at mental disorders, it's 20%. And then when you look at pure anxiety disorder, it's 4.2%. So overall, when we look at the impact of mood disorders and disability, we can see a couple things. Anxiety is actually much, much more common in most of these earlier data, especially in the US, than depression. But then when you look at Europe, you can see unipolar depression is a little bit higher than anxiety, but anxiety and depression are the two most common mood disorders. So let's talk about a real clinical scenario. 45-year-old woman with chronic depression and diagnosed with major depressive disorder since age 40. So she's been suffering from this chronic severe depression for 5 years. She's not responded to any antidepressants. Her annual physical exam and blood work were all normal. What is her future in the healthcare system? So what would happen to her? I mean, obviously at this point, she's gone through all the different list of medications. She's gone through this, this model. Maybe they're going to do, electroconvulsive therapy. Maybe they may try different strategies, but this is a common scenario that we all see. So the real question is, what's the biology behind a mood disorder? What are the different mechanisms that are taking place? And that's not what's happening. What's happening is people are going from diagnosis straight into treatment. Because there's another common clinical scenario. 38-year-old woman with episodes of anxiety that are unpredictable and debilitating. She responds to taking anti-anxiety medications to dampen her anxiety, but she falls asleep and is unable to function the rest of the day from the anxiolytics. So there are so many people that have anxiety disorders. And of course, the anti-anxiety medications can dampen the effects, but they also sedate people and they lose their ability to function. And so what's the 38-year-old going to do for the rest of her life? And is this getting worse over time? And what are the mechanisms behind that? So we're going to go through anxiety, neurology, neurochemistry in great detail, and then talk about how to kind of work through that process. It's definitely not going to be a course where we go, for generalized anxiety disorder, here's your nutritional protocol. And for major depressive disorder, here's your protocol. And for minor depressive disorder, you just do a little bit less. It's absolutely what we're not going to be going through. Okay, here's another clinical scenario that's very common. 29-year-old man noticed that he has lost the ability to be motivated and cannot finish tasks at work. He's working with a life coach, but cannot incorporate any of the coach's recommendations. So what's going to happen to this person's future? He's at an age where he has to, get his life organized and get things going, but he cannot motivate. He cannot finish tasks. And he's trying to work with a life coach, but doesn't have the brain neurochemistry to make things happen. And another common one, 17-year-old girl has episodes of depression and anxiety. She's unable to focus on schoolwork and develop friendships. Her primary care physician told her parents that it's just teenage hormones and she will grow out of it. What's her future in the healthcare system? So her future is very bleak because it's not just teenage hormones that she's going to grow out of. These are much, much more complex. And there is actually biology that's impacting these mechanisms. There's neuropathophysiology that's impacting these mechanisms. Now, when we look at mood disorders, it was initially first just explained by a neurotransmitter deficiency, right? And here's a model where we have, for example, different regions of the brain. Whoops, let's go back. Different regions of the brain, limbic regions, prefrontal cortex, the amygdala, cingulate gyrus, and then there's neurotransmitter deficiencies, and then these cause depression. This is the basic model of antidepressants, okay? And to be quite honest, even in the alternative medicine world, well, depression is really a nutrient deficiency. They don't have enough folate. Oh, wait, not folate, the specific folate, methylfolate. Or they don't have B6, or they don't have B12, but not just any B12, methyl B12. And they go through, or maybe they just need more tryptophan or 5-HTP, and they go through this model of really trying to find mood disorders to be simplified as into a nutrient deficiency for those neurotransmitters. Now, of course, nutrition plays a role, but it's not the main cause of people that have chronic disorders. It's one variable of many that has an impact on lots of variables that impact causing dysfunction in the limbic system. And the same with anxiety. Maybe anxiety is thought to be of just like a magnesium deficiency or a calcium deficiency or something like that. Now, of course, there's some impact with some of these nutraceuticals having an anti-anxiety effect, but the actual cause of a generalized anxiety disorder that's been happening for months and months and months is obviously has more depth and mechanism involved than just a simple nutrient deficiency. So then you get into like green medicine models. And we'll talk about green medicine models. What are botanicals? What are natural compounds that can be used instead of using a pharmaceutical that's natural? Things for depression, it might be like St. John's wort. And there's clinical trials that show St. John's wort has some impact on depression when it's done for a short period of time. Or it's just like, neurotransmitters, use botanicals to support sedation, things like passion flower, chamomile, kava root, for things like anxiety, for example. So the basic model of mood disorders when looking at alternative medicine is basically, yes, there's these neurotransmitters involved, and we can impact them with nutrients, and we can impact them through botanicals, and you can also throw in hormones in there. Maybe hormones are really what they need to impact their functions, whether it's thyroid hormone or these other hormones, and these all have some role to play. But what I'm trying to say is these are the very surface level approaches. And these are typically not going to be enough and address the depth of the neuropathophysiology that's involved with people that actually have chronic mood disorders, the ones that actually walk into your office that may have already tried all these things and already doing all these things. So like, what's next? And then when you kind of step back into conventional pharmacology approaches, basically they classify mood disorders as a neurochemical imbalance. Something's wrong with serotonin, dopamine, GABA, maybe the NMDA receptor. And then for these neurotransmitters, you basically have either a reuptake mechanism, a receptor agonist mechanism, or receptor antagonist mechanism. Then you can classify the 5 major classes of antidepressants into serotonin reuptake inhibitors, MAO inhibitors, serotonin norepinephrine reuptake inhibitors, serotonin antagonist and uptake inhibitors, tricyclic antidepressants, tetracyclic antidepressants. They're all working to try to impact these neurotransmitter levels. And when you look at antidepressants, in the 50s, they first found the MAO inhibitors, which reduced the clearance of epinephrine, norepinephrine, dopamine from the body. And then they started to get into tricyclic antidepressants, which have a reuptake mechanism on things like serotonin and epinephrine, acetylcholine. And then later on, the pharmaceutical industry developed serotonin reuptake inhibitors in the 90s, became a drug where they said it's much safer than tricyclic and MAO inhibitors, and it's much more effective, and they published studies, which we'll discuss, which were severely flawed, and started the antidepressants as the main class of medication use. And we're talking about a $1 billion global blockbuster drug. If you look at the United States, per 1,000 people, 110 people are on some type of antidepressant. That's crazy. It's almost 10%, that's over 10%. So that's unbelievable. So you look at other countries, even like Europe and other places, the more readily available antidepressants are, the more it's used. United States, we hand out antidepressants like candy. There's no biological workup to why someone may have depression. They just try this one. Well, maybe you need to try a different type. Instead of the SSRI, maybe you need SSNRI, and then we need to combine those two together and see how you do, and they kind of go through adding more and more to it, but not really looking at why they have that condition in the first place. So antidepressants are being used. It's one of the most common drugs prescribed. It's in the top 5 most commonly prescribed drugs of all time, every year. Do they work? Well, let's look at the literature. So, first of all, I would tell you that in the whole entire field of scientific studies and publications, there is no field that has been most corrupted and had the poorest quality research published than antidepressants in all of medicine, right? And this is well known. Like if you talk to researchers, they pretty much know, like if you want a bad example of how research is done, if you want to see how the pharmaceutical industry has had a huge influence on getting data published, it's antidepressants. It's like way up here and nothing else is even close. Okay, so that's what you have to understand. Now, before we get into antidepressant research, I want to show you a study that was published where it was titled Placebo-Activated Neural Systems Are Linked to Antidepressant Responses. And what they did is they did a 2-week crossover trial where they wanted to see what would happen to the brain giving a placebo. So they did PET scans of the brain before and after and giving antidepressants. And then when they were done, what they looked at was there a really big difference between taking an antidepressant or taking a placebo? And they found out that the placebo effect was really accounting for a significant impact of the outcomes. So they go on to put in the conclusion of their study, placebo-induced endogenous opioid release in the regions was associated with better antidepressant treatment response, meaning that when they looked at the brain, people thought they were taking something, placebo effect, their brain lit up, their opioid receptor system lit up, and it was actually more effective in the study than the antidepressant. And then they go on to show that predicting 43% of the variance in symptoms improvement at the end of the antidepressant trial. So here you can see the scans that they're using, and here they're using a basic antidepressant drug. You can see some areas of activity, and they look at the severity of it over time. And the less activity they see in the opioid system, the more severe depression is. And then they look at the outcomes before and after placebo and antidepressants. And here with the placebo group, the opioid response is actually much, much greater and much more effective. So this goes on to show that just the placebo effect is going to have some response with almost 50% of the population. So when someone does something that's totally ridiculous, like a urinary neurotransmitter test to see what's happening in the brain, which it does not determine what's happening in the brain, those are peripheral urine levels, and then tries to develop some kind of nutraceutical or amino acid blend to help that, and then they give it to people and go, hey, as a clinician, I see that helps some people. Well, that's because a large part of what just happens in general is the placebo effect. And what's going to be the outcome with them, not in the first initial placebo effect response, which will last a few weeks, but a month later, or 2 months later, or 3 months later. So you should always suspect a placebo effect with anything you give someone with a mood disorder. And the most diagnostic factor that it could have been a placebo effect, that it doesn't hold its effect as time goes on, which you also see with many different types of treatment variables. Okay. Now, this was a paper that was published in 2018, and it went through all the different major studies published in the field of antidepressants. And they go on to say that recent studies not only may overestimate the effect of antidepressants, but also may exaggerate placebo response because of various biases. Sponsorship and publication biases have been one of the targets of criticism in the ethical debate. And they go on to say in this paper, which you should definitely read, the various biases they have. So first thing we have is selection bias. So with these clinical trials that have been done with antidepressants, their exclusion and inclusion criteria are that, first of all, they can't have any other type of mood disorder. Just so you know, 64% of people that have anxiety or have depression also have anxiety. So they would be excluded. If they have any other diseases like diabetes or any kind of medical condition, they're excluded. If they have severe depression or moderate depression, they're excluded. If they have alcohol abuse or substance abuse, they're excluded. And they go on to say that this is absolutely not generalizable to the population that seek antidepressants. The people that actually seek antidepressants have multiple mood disorders, other comorbid diseases, they have substance abuse, they have alcohol abuse, and they're probably only getting about a 20% reflection of what's actually the population of patients that the real clinicians see in practice versus what's been artificially created in clinical trial. So that's a major issue of many of the clinical trials, majority of the clinical trials published on antidepressants. And then we also have some biases where not all the studies are double-blind or placebo-controlled, or some are single-blinded, and these have a huge impact on outcomes. And then the statistical analysis that's used, and I'll go over some of that in a couple slides here, that are used to determine these outcomes are severely biased and flawed. And then most importantly here, publication bias. So let's go about publication bias, because this is the biggest factor. Now, when you look at the data, so if you were a physician, if you're a researcher, and you wanted to look at antidepressants, do they work, do they not work? You'd go through the literature and see what the randomized clinical trials showed. And if you look at the trials that were done and approved by the FDA, there were 74 clinical trials done for antidepressants, okay? 38 of them had a positive result, meaning they found some benefit taking the antidepressant. And you should remember, these are only for like 8 weeks, 16 weeks, these are not long-term. But 36, almost half, showed no effect. And that's okay, that's fine, but this is where the publication bias comes in. Only 3% of negative trials were published, okay, and 44 positive trials were published. This is just how studies are sometimes rehacked with secondary outcomes and other variables, so you can get more studies published out of them. So you have 44 positive trials and 3 negative. Now, why do these other negative studies not get published? Because the study is negative, so the pharmaceutical companies that ran these trials decided not to publish. So now you look at the highest level of evidence, which is to do a meta-analysis. Take a list of all the studies published, on do antidepressants work, and you have 44 studies that say it does work and 30 that says it doesn't work. So you got a problem. Now you have this like, oh, the data clearly shows antidepressants work. But in reality, if you look at almost half of them not working and only 30% working, this would probably just null itself out in a meta-analysis and show that there's really no effect. Now, some researchers have then gone further and looked at how they determine primary endpoints and outcomes in these studies. They took the same data, but looked at the analysis. And when you look at clinical trials, there's a primary endpoint, and then there's different ways that they follow through and look at attrition rates and how many people finish the study. And if the dropout rate is different in one group or another, you can have effects that are completely different. So they were doing these methods where they were looking at a method where the last outcome is carried forward versus per protocol or intention to treat type variations that were used. And they found that when they actually did a proper analysis, they actually found no difference in some of these studies that were published to support drugs that are being approved by the FDA. And overall, they show this intimate relationship between how clinicians and funding and this trend to have only researchers that can find a positive impact keep getting grants and funds versus those that don't, and the study design variations that were done seem to be getting all the funding and all the support, and it really is a big problem. They also found many things that were very interesting, like when they looked at questionnaire forms and how things were done, how they look at the mean outcomes. For example, if they do a baseline mean of a Hamilton Depression score, they say the actual score is 23, but the first time you do it, you don't really understand the question, so you rate higher. And what should be done is you do it over again 2 or 3 times, then you get the actual mean. So if you did a questionnaire form once, it's most likely going to be scored higher, unless you did it 2 or 3 more times and really understood the questions, and then your mean would probably be accurate. So these studies intentionally just do one baseline. They don't get the true mean by doing multiple testing, and then of course the outcome is much, much greater. So what's known in the field of antidepressant research is a lot of misleading results. So they disregard trials with negative results. They use multiple selected favorable results. They conduct subgroup analysis, select favorable results, people that don't have any other comorbidities, any other diseases. They alter parametric results to non-parametric forms and vice versa. This is a statistical analysis method. They choose inferior drugs when they do superiority inferiority studies. And for example, they use higher doses of a competitor's drug for tolerability on a safety trial compared to their new trial, and they may use lower doses for an efficacy trial when they compare one drug versus another. And all this is done is just to get the drug approved so they can make claims for it with the FDA and so forth. So scientists, research scientists, data analysis scientists that look at antidepressants really have found conclusively now in the literature that this data is really not that great, that there isn't really a big effect with antidepressants, and that the effects that have been found are completely overemphasized, and this is very misleading to people. Now, recently in 2022, a group of data analysis researchers looked at, okay, we know this is a problem. We've published on these factors, and other scientists have published on these factors, how these clinical trials were done and the data outcomes were much greater than they really were. Have things really changed? So if we look at clinical trials done recently in the past few years, and we look at the meta-analysis of newer studies versus the older studies that were severely flawed, which still is the reason why we have these antidepressants approved, is there much change? So they go on to say that in earlier studies, using the Food and Drug Administration review documents as the gold standard, found that many negative trials had been misreported in the published literature as having positive outcomes or had simply not been published, right? And they go on to look into, since then, reporting bias has been the subject of additional studies and policy changes, raising the question, is the antidepressant literature now being reported more transparently? Because it is very clear that it was not. Okay. Conclusion, reporting bias remains a significant impediment to researchers and medical decision makers, so further efforts are needed to improve transparent reporting in scientific literature. And basically what they found is when they looked at the, trials, older trials versus looking at newer drugs, that they have improved. These were negative trials in the past, and now they can see that the slant is not as bad, but it's still there. But it's definitely a huge difference than what it was. But most of the drugs that have received approval, most of the mindset that's infiltrated psychiatry and medicine is that these antidepressants are very effective, and if you take them, they should work. And that's really not what the data really showed with these clinical trials when they were critically analyzed. So that then leaves us to, okay, well, do they work, do they not work? Well, the bigger question is, what happens to them long term? Because we know that a placebo effect has about a 43%, almost 50% effect on people randomly when they take something for their mood disorder. The bigger issue is, what about long-term effects? And I think, as most of you already know, working with patients, most people will say, yeah, I tried Prozac or Wellbutrin or some Zoloft, and it seemed to work for a little bit and it stopped working. But they've been on it for now a year, and they can't just titrate off. So now they're stuck on it for years and years and years, and is there any really effect? And one large study was published here. There's two large studies that were published. But this was a study that was published, and they went through the literature asking the question, how effective are antidepressants for depression over long term? Because remember, these clinical trials that are done to get drug approval are done for like 12 weeks, 8 weeks, 16 weeks. They're not long term. And then they go, summary and conclusion. Currently, there is no reliable evidence that long-term antidepressant treatment is beneficial, and there are legitimate concerns that it may be largely ineffective or even harmful in a substantial portion of users. And then this was followed by a recent study that was done 2022, which looked at 17 million sample size over a 2-year period. And what they found was the real-world effect of using antidepressant medications does not continue to improve patients' health-related quality of life over time. Further studies should not only focus on short-term efficacy of pharmacotherapy, they should rather investigate the long-term impacts of pharmacological and non-pharmacological interventions on these patients' health-related quality of life. So they don't work long-term. This is what the studies have shown, and then the actual outcomes that they were initially published for have very little effects. So now we have all these people that are antidepressants. So what does happen with long-term use of antidepressants? Well, there's sexual problems, there's weight gain, there's reduced positive feelings, there's a feeling of dependence on the medication. They're afraid to go off. The doctors are telling them you can't go off. This is you'd be much worse if you didn't take it, which is just a random assumption. There's no real truth to that. They feel emotionally numb. And when you look at the studies that looked at the outcomes and data of side effects that are people that are taking long-term antidepressants, they found sexual problems in 72% of people, including inability to reach an orgasm, 65% of people. So this is over a 2-year period. Weight gain, 65% of people. Feeling emotionally numb, 65% of people. Not feeling like this themselves, 54%. Reduced positive feelings, 46%. Feeling if they're addicted, 43% feel they're addicted. Caring less about people, 36%. Feeling suicidal, 36%. 30% still said they had moderate or severe depression. So now that not only it's not working, not having any effect, but now they have some of these side effects reported. So there is a problem with long-term use of antidepressants. And one of the major problems is, what's the underlying cause to begin with? That's really, really important. Now, this was the title, a paper published called Cellular Molecular Mechanisms in the Long-Term Action of Antidepressants. They go on to say that less than 50% of all patients treated with currently available antidepressants show full remission. The main reason for this is still incomplete knowledge of the pathogenic mechanism of depression and understanding of antidepressant mechanisms. And we're going to go through that in detail. This is a paper that was published, Why Do General Practitioners Prescribe Antidepressants to Their Patients? A pilot study. Conclusion, antidepressant prescription is related to complex contextual situations in multi-morbid patients. GPs use a biopsychosocial approach rather than a purely biological assessment, functional medicine evaluation. Awareness of these influences could improve prescription of GPs. They're just like, hey, you got a lot of stuff going on, you're depressed, here, take an antidepressant. I don't have time to get to it. And that's an issue. Okay, so now when we look at the pharmaceutical approaches to depression, we can see that these neurotransmitter models in the long term don't really work, and the short term, their effects have been greatly exaggerated. And you look at the evolution of antidepressants being used. The 1960s, 50s, where the drugs were developed, 60s, 70s, when the drugs were being used commonly, monoamine drugs were used, and they thought, depression was caused by decreased neurotransmitter availability. And then in the 80s, they go, wait, it's not just the amount of neurotransmitter, it's the receptor. So this is where the serotonin reuptake inhibitors came in the 80s, 90s. And then antidepressants induce adaptive post-receptors. So where's the literature now? So now they're saying depression is really not due to just a neurotransmitter issue or receptor issue, but it's really due to dysfunctional plasticity. That the cell itself is not healthy, that the neuron is not healthy. And I think this is actually very accurate based on all the research that's been published. So it's not a simple neurotransmitter issue. So if you're like seeing a patient with depression or anxiety, and you think, okay, what do I need to do for their serotonin pathways or dopamine pathways nutritionally, thinking that's going to be the only mechanism involved, you're going to fail with many of your patients. So really what you have to think about, especially when you see chronic depression, is that chronic depression is really unhealthy, sick neuron, unhealthy, sick brain, and specifically areas of the limbic regions of the brain. Now, there has been a huge breakthrough in antidepressant medication that we definitely need to talk about, and this is ketamine. And ketamine is a drug that some people that have chronic depression have been suicidal. After like one treatment, it's cured for a period of time, okay? And then some people don't respond at all. But what was mind-blowing is like what's happening with this drug. This was just an anesthetic that was being used just during World War II, and now that's being used as an antidepressant off-label. So what they found is that with ketamine is that it actually turns on activates the NMDA receptor, turns on the glutamate receptor response, activates BDNF, brain-derived neurotrophic factors, which you need for plasticity, and it actually turns on signals to promote growth factor release and make neurons function much better, that it's not just a neurotransmitter response. And ketamine is now used in very severe cases of depression, suicide, and has some effects with some people. And this is also important for you to know because, you guys, there is no doubt there are people you're not going to be able to help with a nutraceutical functional medicine model. They're just not. They're not going to respond. And if they are suicidal and if they have no hope and they just really want to try something, their GPs may not even know about ketamine, right? So it's something that they should look into and learn about. Now, most of the research that's been shown to have effects has been done with an IV source called the R source, and then there's the S molecule version, which is a nasal spray. And the things you need to know about ketamine is that when they do the IV treatment with it, and it works, people usually respond within 1 to 3 infusions. If they don't respond to 3 infusions, they just give up and say, this is not going to work. If a person has no response at all, further infusions are unlikely to help. People who experience some relief from depression with 1 to 3 ketamine treatments are probably likely to extend these positive effects if the treatment is repeated several more times. There are no standard guidelines for this. Many studies offer 8 treatments in the acute phase. After this, patient doctors decide whether to taper off. It is highly, highly addictive. So that's another key issue. And they won't even use it with people that have addiction issues. And not to say that this is the future, because it's not. It's very limited. People get addicted to it. It has some effects on people. But when people get in a crisis situation, this may be appropriate. The most important thing about ketamine was the realization that it's dysfunctional plasticity that may be the biggest factor, that it's not really just an individual neurotransmitter that is involved, right? Now, neurotransmitters can have some influence in depression and mood. We can definitely use nutraceutical approaches for that, but it's not the main mechanism. So what are underlying causes? What are physiological causes of mood disorders? So let me go through a list of these, and these are just important to understand. Because one of the things we have to go through is how do we define these in a clinical practice? How do we evaluate them? How do we treat them? How do we find them? And so forth. So mood disorders can be caused by, you'll see serotonin imbalance, dopamine, GABA, acetylcholine imbalance. And I use the word imbalance because it's not necessarily a deficiency. And a better way to really think of it is there's inefficient serotonergic transmission. There's inefficient dopaminergic transmission. There's inefficient GABAergic responses or transmission. Those pathways are impaired. It's not a deficiency of a neurotransmitter. It's more likely that the signaling pathways are altered, or those circuits need greater support for their underlying neurological factors that are there. But neurochemicals definitely have some role to play. But to limit all of depression to them alone is not the issue here, okay? There's hypothalamus pituitary adrenal imbalances. We'll talk about some of that research, hormone imbalances, thyroid dysfunction, dysglycemia, neuroinflammation, gut-brain axis. So here's just a list of some of them. There's obviously many more. So, you can go down this tract for people with mood disorders. But another common one is just brain injury. People injure their brain. They get mood disorders. And the injury could have happened 5 years later, at 10 years, 5 years before their symptoms, 10 years before their symptoms. People have vascular injuries, people have silent strokes. If it impacts their limbic regions, then they can have a mood disorder. Then people have neurodegenerative diseases. So neurodegenerative diseases can definitely play a role with mood disorders. Anytime you see anyone that's older in their 60s, and they're having other types of symptoms, you got to make sure that they don't have early neurodegenerative changes that are taking place. Childhood neurodevelopmental disorders always have mood disorders as a part of it. So you should expect to see them in all children with neurodevelopmental disorders, because these limbic regions do get impacted with these delays. But, children that have autism become adults that have autism, and children that have ADHD become adults with ADHD. So you have to see if there's some component to lack of neurodevelopmental tracks. And remember, by age 18, 21, the white matter and gray matter fully develop, so whatever development they have is a key part of their susceptibility to having variations in daily life impact their mood. And then there's definitely a lot of neurological autoimmune diseases. There's lots of demyelination. People get antibodies to GAD65, the enzyme that makes GABA, and get anxiety disorders. People can have gluten ataxia or cerebral autoimmunity, and feel like they're falling all the time, and have anxiety disorders from the autoimmunity that's underlying it. And people can have psychological issues that may be causing mood disorders. And one of the things you have to do as a clinician when you see mood disorders is this first step. You have to evaluate whether the mood disorder is primarily due to physiological imbalance or psychological imbalance, okay? If someone says to you that they lost their job, they're going through a divorce, they're going to have mood and depression, anxiety issues. That's primarily a physiological problem, right? Now, some of it could be due to the amount of physiological resiliency they have. We'll talk about resiliency later. That's another concept. So not everyone that has the same amount of stressors in life is going to have the same impact on their physiology to cause a mood disorder. And what's going to determine that is their resiliency. But there are times where the situation is primarily psychological, right? Now, a physiological mood disorder is based on a physiological mechanism. Psychological is based on some other type of mechanism that's impacting their well-being. So, for example, you can have a patient that's chronic leaky gut and chronic stress responses, chronic adrenal glands that don't respond to any kind of application or treatment, and they are living with a spouse that's abusive. There's no amount of glutamine you're going to give their leaky gut to fix that until they move the cells out of that environment where their physiology have a chance to respond. So those are the things you want to pick up on as a clinician, right? What's happening in their life, or is there any psychological factors that are causing their mood disorder? And obviously there's always some interlap between physiological mechanisms, psychological mechanisms. They both impact each other. And what you're trying to look for is one predominantly psychological, right? And then in that case, their outcome is going to depend on some psychology interventions, whether they find peace, maybe they change their environment, maybe they improve their resiliency, maybe they do cognitive behavioral therapy, maybe they do something to address the psychological aspect of their care. And then secondary support could be physiological. You still want to support their health, meaning, for example, if someone has psychological mechanisms why they may have a mood disorder, like unhappy with life decisions, maybe they made bad decisions in their life, now they're totally depressed, guilt from life choices, lack of self-worth, no life purpose, loss of friends or family, financial problems, relation problems, they're going to cause mood disorders. And they may come into your office with like food sensitivities and leaky gut. And they go, I just want to get rid of these food sensitivities. And you go back and go, wow, you have like all these other factors. There's only so much we can do. And this is where clinical management comes into place. In those scenarios, maybe you're like, okay, Until you get it out of your unhealthy psychological environment, we're going to support your physiology, but we won't expect any big change until you can leave this stressor that's impacting your physiology out of the picture. So that's a key thing. Things like microbiome disruption, like you'll never see GI panel change. They'll never get a dysbiosis when they have a chronic physiological stress response. Or their immune system may just never be able to strengthen and deal with a chronic virus because their psychological demands and stressors put on them are way too great. Now you got to be careful because this is also the ultimate cop-out. Well, it just must be due to stress, right? So there's a balance between these two. And you can definitely improve what's called resiliency. We'll talk about improved resiliency later to make these things have less of an effect, but you got to know what you're dealing with in clinical practice. So you have to always ask those questions. Now, sometimes, you have patients come in and say, I'm totally depressed. I don't know why. I don't have any stressors. I've been successful in life. I'm retired. I love my kids, I love my family, everything is great, but I have chronic depression. That's different, okay? That's when you have primarily a physiological issue, okay? Now, when you do have people that have psychological issues, and the secondary support, they could benefit with a support group or whatever, but your goal as a functional medicine practitioner is to help their physiology. When you're dealing with practitioners that have primarily psychological issue, here's a key clinical concept. Do not play the role of a psychologist in a functional medicine practice. Don't have your staff play the role of a psychologist in a functional medicine practice, okay? There's no better way to beat you up emotionally where you don't want to see any more patients and want to quit practicing than listening to all the patients' life problems. And some practitioners, especially new ones, are very naive. They just think they're not being polite. They're just thinking like they're not being nice. And then they have office staff that feel like they're not being polite and nice. So you can literally have someone that has depression and mood issues spend 3 hours with your office staff just telling how bad things are. And that wipes out your office staff, and they don't want to come to work, and they don't want to deal with anything. So it's got to be like a line to draw. All focus is to improve your physiology and health. We're gonna see what's going on. Also, be very careful with how you follow up patients' questions. People have chronic mood disorders. How is your reactions to food versus how is your depression and mood? Are you happy? Like, don't ever go in there, are you happy? Are you sad? That's not the question you want to ask as a clinician. How is your blood pressure? How's your blood sugar levels changing? How's your cortisol response changing? How's your gut profile? These things all impact your resiliency. Let's focus on those issues. Our goal is to change your physiology, to change that. So you got to be very careful. And there's a lot of practitioners that don't like working with mood disorders, and the number one reason is because they feel like they have to play psychologist. And there's also many front office staff and people who work in your office that don't like working with some of your patients. And if you really go down and listen to what's happening, because they're laying all their emotional stuff out on them and they're making themselves allowed to do that. So you have to let them establish boundaries. I'm not allowed to talk or hear about your medical conditions or personal issues. I'm sorry, they have to excuse themselves or do things. They have to get themselves out of that environment, whatever is appropriate for them to do. Okay. So those are the key things with the psychological types of mood disorders. Yes, if there's primarily psychological, you have to treat some of these other issues, but really you want to try to focus, and you have most success with those that have a physiological response. Now, key clinical concept. The duration of their mood disorder can help you identify the underlying mechanism and potential prognosis. So what do we mean by the duration of it? So if someone has a recent mood disorder, the prognosis is good. They recently had some anxiety issues that popped up the past couple months, or some depression the past couple months. They can't shake it off. That's when, maybe you just got to do a very thorough history and find out, they stop working out, they have a sleep disorder, not sleeping, there's more stress in their life, their blood sugar is dropping all over the place, they have some hormone imbalances, and you can do some lifestyle, functional medicine approaches and see these things change. So, recent mood disorder, let's say less than 6 months, is good. Those are usually have better prognosis, and the mechanism is usually more neurochemical imbalance. Now, if it's another type of mood disorder is intermittent and relapsing. They don't have any problems, boom, they're down, and they're having problems for several weeks. And then they're fine, and boom, they have another mood disorder. Whether it's depression or anxiety, that's when you're more concerned about like primed glial cells, underlying neuroinflammation, underlying autoimmunity, a thyroid dysfunction, hormonal imbalance, the prognosis is a little bit different. And when you see someone who's got chronic mood disorders, like the first case example picture I showed you of a 45-year-old female that's been suffering from major depression since age 40, major depressive disorder, nothing's helped, then you may have like a brain injury that no one's identified and managed or supported. Maybe they have early signs of neurodegeneration, maybe the brain's atrophying. Maybe they have an undiagnosed metabolic condition, and it could be as simple as like a thyroid disorder no one found. And if someone's had lifelong mood disorders their whole life, there are genetic disorders. There are people that don't have efficient dopaminergic receptor responses. There are people that have dysfunctional GABAergic receptors, and they have anxiety disorders in their whole family from the very beginning, and nothing ever helps it. And they can take anxiolytics to help take the edge off, but it's lifelong. And if you're gonna go into those cases thinking it's like a magnesium deficiency, or you need to give them some Valerian instead to forever cure it, it's different. Those are conditions where you go, hey, you've had this forever. How do we help you function with what you have the best you can? So you have a tendency for anxiety. What are things we can do? So what are maybe natural anti-anxiolytics we can do so you don't have to be totally sedated? They can take the edge off, right? What if we found a relationship with your mood disorders are much, much worse when you're hypoglycemic? What if we manage your hypoglycemia and see if that has an impact on how your genes express? Some children that don't have proper neurodevelopment, especially in those limbic pathways, would be very, very prone to having extreme reactions to things that may not impact them into depression, or other people into depression, or them into anxiety that won't impact other people too because of their abnormal limbic circuits. Some people have permanent brain injury, and those limbic areas are not working very well, and they're going to deal with depression ongoing. Now, again, not to say you can't do anything with them, but you need to know what your prognosis is. You can definitely do things to improve function and quality of life with most people. You just want to know what's going on with them. Like if you had someone who had brain injury 5 years ago, had no symptoms, and now has some of their chronic inflammatory symptoms get worse, and you think that just giving a multivitamin and some amino acids for their mood is going to make a difference, you may just be frustrated, and they get frustrated. So this is why it's so critical to understand the pathophysiology and the potential prognosis. So the other key clinical concept when we get into mood disorders is once you identify the underlying mechanisms of a mood disorder, you will need to determine if the underlying mechanisms have the potential to respond to care. May or may not respond to care. So the term I use is, once you find the mood disorder, is the underlying mechanism responsive to treatment, or is it resistant to treatment? So let's talk about the ones that are responsive to treatment. So you find out they have hypothyroidism. That's very easy to get managed and treated. They have abnormal menstrual cycles. They have nutrient deficiency. They have autoimmunity. They have a head injury, and they actually do respond to some things when they go through various treatments or applications in their life. So those are all ideal. These are responsive to treatment. Then you can have those that, again, have genetic disorders or atrophy of their brain, and they may not respond ideally. They're resistant to treatment. That's another key issue you have to identify right away. Even in those cases where these factors are there, you can obviously optimize their neurochemistry and the stress resiliency. And we're going to talk about that a lot. These are the main things that disrupt mood and stress resiliency. So if you have someone who's got a blood sugar issue, someone's got a lot of stress, someone who has a sedentary lifestyle, someone who's inflamed, someone who's microbiome imbalance, they're more prone to have the same trigger cause depression or anxiety or flip to bipolar than when someone who doesn't have these dysfunctions or these mechanisms that are involved with them. So even in worst case scenarios, you want to improve your resiliency. So when we get to management and treatment approaches, sometimes the approach is to treat the underlying mechanisms, sometimes the treatment approach is to deal with the underlying resiliency patterns. And once you go through your clinical evaluation and your workup, you're really left with, is your clinical scenario psychological, meaning you need to refer out for psychological support? Hey, what you really have needs to be addressed by dealing with stuff that's going on. You need to get through that first. And that could just be your clinical gut feeling of what you want to do with that. There's some patients you may not want in your office. There's some patients who just feel like they're going to waste their time being in your office. They need to address other factors first. And then there's others that you may want to support their health. Let the patient understand limitations of functional medicine approach. They're going through some challenging issues, but it's really impacting their bloating and distension, and maybe they have inflammation because of it, and their body hurts and they can't sleep, and they just want you to help improve their quality of life, and they understand that their primary issues, their psychological environment, that's a factor. You may have a patient has a physiological response that is manageable, like an underlying mechanism that can be responsive to care. And then you may have a patient who's got unmanageable causes where you have to improve resiliency and so forth. The most important thing is in a mood disorder, you understand these possibilities all exist and you establish your role. Like, you have a highly stressful situation that's happening in your life. This is impacting your physiology this way. We can try to impact that physiology with different approaches, but we're not going to expect a cure. We're just trying to have you function the best you can under your current circumstances. That's one way to deal with a mood disorder. Another way to deal with a mood disorder is, wow, you have panic attacks. And you have panic attacks, but it looks like you really have maybe some chronic traumatic encephalopathy from your head injury years and years ago that haven't been diagnosed. And you really have this neuroinflammatory model. And then you go after that approach for their anxiety. Okay, now when you look at the categories of mood disorders, let's get into this one here first, depression. Now, the really important concept that I want to explain to you. Mood disorders are caused by dysfunction in the limbic system, okay? And where that dysfunction is in the limbic system is going to cause various types of mood disorders, whether it's major depressive disorder or OCD or generalized anxiety disorder. You don't need to memorize or try to develop protocols for every single different mood disorder. It would be very inefficient. So you just want to understand what the mechanism is and then go from there. So for example, when you look at depression, if you really look at the neurology behind it, which we'll do more in the next presentation, the prefrontal cortex regulates emotions, critical thinking, problem solving, and planning. So dampened function here is really the main issue. And when you look at the pharmacotherapy of major depressive disorders, their main focus is looking at neurotransmitter, which is only a very small part of the big picture. Contemporary literature on depression shows that, hey, when we look at a healthy brain versus depressed brain, we see people who have depressed brains have higher stress hormones, higher insulin, higher degrees of inflammation, higher degrees of oxidized molecules, less growth factors, less antioxidants, less plasticity. Those are the things that are involved with really people having severe depression that then impacts their frontal lobe pathways, where they have emotion and cognition and planning and executive functions and so forth. And you see this study that was published looking at molecular mechanisms of depression, and they go mechanism leading to resulting from depressive disorder, and they go like, listen, it's not necessarily a neurotransmitter issue, but it could be their chronic insulin issues or systemic inflammation or their chronic stress responses or their unhealthy vascular tone or early neurodegeneration that may be leading into their depression. So one of the things I just want to quickly review here are some of the main mechanisms that decrease frontal cortex activity and lead to depression, okay? Now, hormone imbalances are for sure a factor. Like when they really become low in testosterone, and women when they become really low in estrogen or progesterone or thyroid hormones, they can have some changes in the mood, right? And hormone imbalances reduce postsynaptic neurotransmitter activity. We'll go into that more detail later. It reduces mitochondrial ATP output, and those things can lead to dysfunctional neuronal signaling. And dysfunctional neuronal signaling in the limbic lobe can cause mood disorders. If it really impacts the frontal cortex, that can lead into depression. And when they look at these, different PET scans, when they look at what's happening with depression, and when they go to treatment, here you can see a PET scan demonstrating activation of the limbic system with thyroxine in treatment of hypothyroid patients. So you can see, for example, the changes in activity of the frontal cortex with and without thyroid hormones. And you can see that everything seems to function much better with thyroid hormones than the overactivity of their limbic regions when they don't have them. So the region of the brain that's involved in the main circuits of the limbic lobe are the frontal areas of the brain. Now, neuroinflammation also has been a major factor in dysfunctional neuronal signaling. There's multiple mechanisms that are listed here. We'll go into those in detail. And when they do studies, when they look at the biomarkers of patients with major depressive disorder, they definitely see inflammatory markers as a key factor between those that have depression and don't have depression. So lots of cytokines, lots of inflammatory markers that are involved in inflammation. And inflammation is going to disrupt neuron transmission, it's going to activate microglial cells, it's going to disrupt neurotransmitter pathways. The kynurenine pathway, which we'll get into much more detail, is involved. How astrocytes work with neurotransmitters at the synapse are involved. So those are all key factors. And then studies are also showing now that SSRIs and tricyclic antidepressants may be working for some people because they initially, in the very acute stages of use, have an anti-inflammatory mechanism, that they actually dampen neuroinflammation. So when they look at some people that go on an SSRI or tricyclic antidepressant have some improvements, one of the things they're seeing is that their pro-inflammatory markers are coming down. So they're not even working through the neurotransmitter model, but they're working by having some of these anti-inflammatory effects. And then neurodegeneration can be a factor with people that have the depression. I mean, if the brain atrophies, especially areas of the frontal cortex and limbic regions that project into the frontal cortex, you can have depression. And then neurotransmitter signaling with patients with neurodegeneration are involved. Lack of healthy blood flow to the brain is a major cause for depression. So like if you guys see a patient that comes in and they have cold feet, cold hand, fungal toenails, they have peripheral arterial disease, they have chronic venous insufficiency, they have really bad circulation, that could be their cause. They may have nothing to do, may have no issue, maybe no issues with neurotransmitter problems or anything of that nature. So the vascular endothelium has been linked to depression. If it's inflamed, if it's unhealthy, if there's unhealthy amounts of blood flow, that's a key factor. Reduced plasticity, meaning the brain is healthy. It can release brain-derived neurotropic factor. That can be a huge factor in causing patterns of depression. And we'll go into all the different things that impact BDNF levels. The most important one is just activity, cognitive activity, physical activity. If you don't have that, your BDNF levels go down. And then chronic stress responses have their effects that cause neuroinflammation. So when we look at these major depressive disorders, whether we want to label it as major depressive disorder, minor depressive disorder, recurrent bouts of brief depression, there are these underlying inflammatory, vascular, neurodegenerative, BDNF, growth factor derived mechanisms that may be playing a role. And that's where you have to go clinically when you look at these conditions. Now with anxiety disorders, and by the way, when you look at major depressive disorders, what I did for you in your notes is I made a little chart and a scale for the diagnosis. Now our clinical focus is on trying to diagnose it perfectly exactly by all the different criteria. You should have some familiarity with it, but our focus is to really get into the pathophysiology and the treatment models and so forth. So major depressive disorder is basically symptoms of low mood, low self-esteem, loss of interest for at least 2 weeks. So you can see after 5 or more of these symptoms for 2 weeks. So I have these charts for you for each one of these. For minor depressive disorder, the individual must be experiencing 2 to 4 depressive symptoms during a 2-week period. Doesn't meet all the full criteria for major depressive disorder, it's only 2 to 4 of these depressive symptoms. And then reoccurring brief depression, they have 6 to 12 times a year. The duration of episode is typically 5 to 7 days. So I just wanted to give you some notes to clarify these terms if you haven't heard them regularly, because you're not dealing with the literature on mood disorders all the time. Dysthymia is basically people that have these just depressed characters from birth, and you have to make sure that you understand that so you don't think they're totally depressed, but it's just part of their genetic makeup. And then premenstrual dysphoric disorder isn't just PMS, because many of these women that have this just have changes in their symptoms in the luteal phase of the menstrual cycle, but they actually have normal menstrual cycles. Some don't, but many do. And the theory is that there's increased limbic sensitivity to these hormones. And when they do PET scans, they can see different changes in those frontal lobe circuits with women that have premenstrual dysphoric disorders. And then you get into like seasonal affective disorder, where as changes of the seasons have an impact in their projections to the frontal cortex, to the serotonergic pathways, to the suprachiasmatic nuclei, and so forth. But ultimately, they're not getting enough activation through those pathways to light up the frontal cortex. And for most people you'll see in your practice, it might be unspecific. Depressive disorder may not fit any one of those criteria, but those are the various scenarios. And then you get into once you get through the diagnosis, let me give you some case examples and kind of let's go through this. So let's say you have a case example of a 22-year-old soldier who's had several brain injuries during his military service, has lost consciousness from traumatic brain injury. After his service, he starts to develop depression. He consults with his physician. Over time, he's placed on various combinations of pharmacotherapy and cognitive behavioral therapy with limited success. He also tries anticonvulsive therapy and feels much worse. What's his predicted outcome? His predicted outcome is poor in the healthcare system because he has a brain injury and he needs to work with someone that can help improve the health of his brain. And that's going to be a key factor of getting him out of a state of depression. Here's another scenario. 35-year-old male has had intermittent depression for the past year. He consults with an anti-aging doctor. The anti-aging doctor runs a comprehensive hormone profile and thyroid panel. Everything is within the normal reference ranges. The doctor decides to place him on a protocol of testosterone and thyroid hormones because the doctor feels that his levels are not at ideal levels. What's the predicted outcome? Well, you put any male on testosterone and thyroid hormones, there's going to be a change in mood for a period of time. And then you can have severe depression. So, what's the problem with this scenario is the underlying cause is not being identified. And the assumption is that if they respond to hormones given to them, that it must be the right treatment is an inappropriate conclusion. And typically these types of patients have benefit for a while. They keep overdosing hormones. Then their hormone receptor sites shut down. Then they have a whole host of other types of symptoms and problems. And then they get stuck in this mess. And then they kind of just fade out from working with their person who was being modulated hormones, and they're out there trying to find some help. Here's another case scenario. 60-year-old male has been diagnosed with major depressive disorder. He has been suffering from chronic depression for 5 years. He consults with a functional medicine doctor who orders a urine test to measure his neurotransmitters. He feels that the patient may have a methylation defect. Doctor places him on neurotransmitter nutritional support and methylfolate. Well, this is very, very common. So first of all, urinary neurotransmitters are not valid tests to assess brain function. They are produced peripherally. You guys, the amount of serotonin you have in your prefrontal cortex is different than the amount of serotonin you have in your mesencephalon, the amount of serotonin you have in your raphe nuclei, the amount of serotonin you have in your enteric nerve plexus. They're all different, and they're all different at different times. To do a urinary test to find those neurotransmitter levels being in and out of balance is a complete fraud and joke. So be aware of that. So they're going to get some random levels of the test. Now remember, urinary neurotransmitter testing was developed to identify tumors. Like if you have various gastrointestinal gut tumors, raise and produce serotonin levels. So you get very, very high serotonin levels. Various adrenal tumors will really increase epinephrine, norepinephrine levels. They were never designed to measure brain neurochemical function. So anyways, I'll be aware of that. So if she's doing a urine test, then look at neurotransmitters to determine some kind of protocol, and then the patient just feels they have a methylation defect because, that's cool, and then places them some methylfolate, the outcomes are going to be mixed. It's just going to be random if they get better or not, but they haven't really done anything to look at their underlying mechanism. So that's the problem we have with these different clinical scenarios. I'm sure you've seen all of them. Okay, so that was just some talk on depression. Let's move into anxiety disorders. What are some general things that cause them? And then go over some case examples of what happens in the healthcare system. So with anxiety, when you look at these limbic regions of the brain, the amygdala, which is like an almond-sized shaped substance, and amygdala in Latin means almond, is what really leads to anxiety. And if there's damage to the amygdala, then there's loss of fear and aggression. So this amygdala center creates our fear and anxiety, which we need to keep safe. But if it's overactivated on an ongoing basis, then we can have some types of anxiety disorders. So here you can see images of key brain regions involved, generation of regular motions of threat detection, and you can see the amygdala is a key area. Other areas of the brain involve hippocampus, memory and recall, prefrontal cortex, judgment, executive functions, cingulate cortex, which also regulates emotions and activates the hypothalamus for the stress response. But the key feature is this amygdala is involved, right? So something is causing the frequency of firing of the amygdala to go up, or something is not allowing for dampening of inhibition pathways to the amygdala. That's leading to fear and anxiety disorders. Now, the key features of fear and anxiety disorders are three key factors. First, there's disproportionate and enduring fear. There's disproportionate avoidance of perceived threats, and they have panic attacks. And with the differential diagnosis, there's no lab test, imaging studies, or objective test diagnosing anxiety disorders. The differential diagnosis of anxiety disorders is to rule out any underlying medical conditions. So we'll talk about using questionnaire forms to evaluate this and go through the process. Like with all things, anyone has anxiety disorder, you got to make sure they don't have actual pathology. I made a chart for you for your notes that goes into the most common medical conditions that cause anxiety. They're pretty rare. Most of the people you're going to see in your clinical practice are not going to have these issues, but you need to be aware of them. And then you have all these different subsets of different mood disorders that are not necessarily due to severe underlying pathology, like thyroiditis or something. Now, when you look at generalized anxiety disorders, the key thing is that they have symptoms must be consistent and ongoing for at least 6 months, excessive, uncontrollable, and irrational feelings. Then I made just a chart for you for the diagnostic criteria for various things, like panic attacks. Maximum degree of symptoms occur within minutes. Okay, so let me skip into this one here. Let's skip these examples here. Then you have PTSD, someone who's got like a traumatic brain injury, or not necessarily traumatic brain injury, but traumatic emotional response that then has stress responses that are triggered longer than 1 month or after an event can lead to these patterns. And, OCD, those are all there. But let me go into not just the basic diagnostic criteria for each of these things, but how these things could be clinically managed and clinical strategies. So first of all, the underlying cause could be identified, like a thyroid disorder or adrenal tumor or vestibular disorder. They could be given nutraceuticals to improve their physiology and so forth. But those are not necessarily the main things that need to be addressed. Okay, now let me cap here. Now we'll go over the neurology of anxiety disorders in greater detail in the next section. What I want to do is also go over bipolar. Now, bipolar disorders are definitely not as common as depression and anxiety disorders, but you will definitely see them in a functional medicine practice. And bipolar disorders have this mania stage, hypomania stage, or this depressive state. And they go back and forth between those. So in their mania state, they just can't sleep. They're thinking really high of themselves. They're distracted by everything. They have rapid shifts in conversations. They're just really, overactive emotionally. And then they go right into potential states of depression. And then the depression states may not even be functional. They may not have proper sleep. They may not be able to take decisions properly, have too much guilt, all these various things. And they have these ups and downs, and there's bipolar 1, where the mania is the main feature, and the mania is usually more severe. And then you have the bipolar 2, where you have these mania and depressive symptoms that kind of work with each other. Here you can see like these 2 episodes of depression here. But ultimately, what's happening with them is that there is these abnormal circuits that are occurring. And these abnormal circuits are really due to injury to these pathways. So with bipolar disorder, there's some genetic and epigenetic issues that then get turned on by environment. Then they create an inflammatory response. And then these limbic projections and pathways are always susceptible to inflammatory triggers that then cause them to go into a mania state or into a depressive state. But here you can see another illustration of that. There's some genetics that are involved with various immune pathways, receptor signaling pathways. There's some environmental triggers, some epigenetic effects. There's changes in neurons, changes in circuits, and then anything that causes allostatic load, oxidative stress, inflammation, metabolic syndrome, then can really turn the expression of these inflammatory pathways. Here's a way that this is simplified. So genetic susceptibility plus environmental trigger, damages to the networks of the brain. The glial cells are activated. This causes structural brain changes. And these can impact white matter and gray matter. It can cause mitochondrial dysfunction, alterations in limbic signaling, and this then leads to white matter injury and increased limbic metabolic activity, phasing occurring configuration of limbic network activities, and co-manifestations of manic and depressive states. So think of like these pathways have not fully developed and connected to each other, and they're inflamed, and that inflammation is ongoing and active, and anything that triggers that inflammatory microglial response will then trigger their bipolar activity. That's what you see with bipolar disorders. And these, you're not going to cure these with any kind of protocol. What you're trying to do is improve their quality of life, make their depressive and manic phases less severe. And when you look at the changes in bipolar disorders, in adolescence, there's an acute phase, white matter hyperintensities. Then adulthood, they go into a progressive phase. There's widespread microstructure alterations in white matters in the limbic system. And then in adult stage, they get just chronic loss of gray matter, especially in the frontal regions of the limbic system. And then anything that triggers their inflammatory response can really cause some of these mood episodes. And then when they're not inflamed, they're in a non-activated state, a balanced out state. So studies clearly show that the inflammatory response is directly related to their mania phase. Like you can see people that have bipolar disorder, their inflammatory triggers go up, their mania goes up, the inflammatory triggers get activated, they can go into a depressive state. That's the key feature of bipolar. So what's great is they found this direct link to inflammation, and things that activate their immune system can be some of the variables. Like for example, you could have someone who's got peripheral systemic inflammation, they get these neuroinflammatory responses. These neuroinflammatory responses activate these mania and depressive zones, and they've actually found a relationship with the CRP levels with bipolar disorders, indicating that they're going to have a flare-up, and then they get into their mania stage or depression stage. And when their CRP inflammatory markers go down, they can go into their euthymia state or their non-reactive state. So there's a strong relationship with inflammation with these types of patterns. And there's a list of medications they use. But those are the key features of bipolar disorder. And cyclothymia is just a less severe form of those patterns. And then some people have like bipolar patterns that are basically not specific to any clear diagnosis, but there's actually alteration in limbic circuitry, and they have this underlying pathophysiology, and those are the factors that could be involved. So let's go through some case examples. A 50-year-old male software engineer has been diagnosed with medically managed for bipolar 2 in his entire adult life. He has sought alternative medicine approaches, but prescribed more than 30 supplements. He didn't notice any significant differences taking them. So what's the predicted outcome? Well, the question is, what are the supplements, what they're using? More isn't always better, but it's really lifestyle triggers, physiological mechanisms that activate the glial system. And we're going to go through the list of things that activate the glial system. Their blood-brain barrier integrity is critical. How their microbiome impacts their brain is really critical. But looking at all those different variations and variances is what's going to make the biggest difference when it comes to managing these types of mood disorders. Now, if we go back to some of these case studies we had with anxiety, let's talk about some of these. 48-year-old male developed PTSD after a traumatic motor vehicle accident. So I'm working with a counselor and taking anxiolytics to control symptoms of anxiety. Over the past year, his anxiety attacks have gotten much more intense and more frequent. So the car accident itself impacted PTSD. Now, there could have also been injury to the brain. So the question is, are you going to treat this as a person who has a nutrient deficiency, or are you going to treat this as a person who's got an injured brain? And this is the things that I really want to go into detail with when we get through the course. Okay. Now, let's go through here into the summary. So you have different types of mood disorders. You have depression, major depressive disorder, minor depressive disorder, recurrent brief depression, dysthymia, premenstrual dysphoric disorder, seasonal affective disorder, unspecific depressive disorder. So The ones you're really worried, let's talk about major depressive disorder first. The ones you're really worried about, the ones that have depression for more than 6 months. That's when you got to find out and find a mechanism. When you see the word major depressive disorder, you should immediately think of a unhealthy brain. A brain that doesn't have potential for neuroplasticity. A brain that may have lack of blood flow, may have chronic inflammation, may have mitochondrial impairment. Don't play with the neurotransmitter model only for them, right? Don't think it's just like 5-HTP or buchanopurines or those types of things. You can use those to help with symptoms and mood for some people, but it's only going to have a little bit of an effect, and it's probably not going to last very long. Now, your minor depressive disorders and your recurrent brief depressions can be very, very severe. When you see the word recurrent brief depressions, that's when we talked about that intermittent relapsing type of depression. So whenever you see someone who's got this intermittent relapsing type of inflammatory response, where they're good and they get flared up and they get good and they get flared up again, you've got to think about autoimmunity. Autoimmunity is a major cause of that. Now, autoimmunity, when you look at mood disorders, can be to the brain myelin proteins itself, like myelin basic protein or myelin-associated glycoprotein. It could be to pathways like GAD65, GAD65, that's the enzyme that makes GABA. And people that have GAD65 antibodies are highly associated with like celiac disease. They could have an inflammatory reaction take place in their brain and shut down their entire GABA production from exposure to gluten. You have some people that had GAD65 autoimmunity that have nothing to do with gluten. They just have something that triggers their autoimmune response. And maybe they had a combination of variables that impacted them. Maybe they have the GAD65 autoantibody, they had a high sodium meal, sodium increases Th17, they haven't had sleep for a while, and they get exposed to a common cold, and then they get in a fight with their friend the same day, and all those variables now cause their autoimmunity to flare up, their GAD65 is up, now they have this reoccurrent episode of anxiety that lasts for the next 2 weeks. And they're trying to figure out what happened, what was so weird, and so forth, but it's not really weird. So once you find out that someone has recurrent brief depressions, or recurrent brief or relapse remitting patterns, your number one clinical thing to think about is going to be autoimmunity. And then as you look at these anxiety disorders, what the big issue with these is either something causing these limbic systems, these amygdala pathways to be activated, or something that normally inhibits it is not working. So those are the things that you really want to evaluate and go through. And then ultimately, when you look at the summary here, this is what you're after. Do they have neurochemical imbalances? Do they have a brain injury? Do they have traumatic brain injury? Do they have neurodegenerative diseases? And so forth. So I just spent some time talking about this. Let me expand about this, the neurological autoimmune disease component. Anytime someone walks into your office and they've been diagnosed with Hashimoto's, MS, Crohn's disease, ulcerative colitis, or any other autoimmune disease like RA, you've got to consider the fact that their undiagnosed and chronic mood disorder, especially if it's intermittent relapsing, is really from their autoimmune response. So that's when you want to look at these antibodies. The most common neurological autoimmune disease and mood disorders is actually cerebellar autoimmunity and gluten ataxia, where a person gets antibodies to their cerebellum and brain or GABA pathways, GAD65. These are all associated with celiac and gluten sensitivity patterns. And then their body, their body's integration system of vestibular inputs that's gated by the cerebellum isn't working properly. So they feel like they're falling all the time, even though they don't feel like they're falling. Their brain feels like they're falling. They get anxiety all day. I'm going to show you a case study about that at the end of the course. We have a couple of case studies to go over. And that's very important. You have to understand that a lot of people will have depression as their earliest symptom when they start to get Alzheimer's disease and neurodegenerative diseases. So things like Alzheimer's disease, vascular dementia, frontotemporal dementia, Parkinson's disease, Lewy body disease, these are all things that can cause people that have chronic mood disorders. And with them, you have to really work on their neurodegenerative disease. You got to get their brains healthier. We're going to talk about strategies to do that. But ultimately, if you're seeing someone who's above 60 has any symptom of neurodegenerative disease, maybe you do a Montreal Cognitive Assessment form and you see some cognitive decline. Maybe you see that they're starting to lose activities of daily living, then you know they may have some type of dementia pattern. Maybe they have rigidity and stiffness, then you know they may have some type of Parkinsonian pattern. Those are really important to pick up on. Brain injuries are one of the most overlooked causes of chronic mood disorders. And one of the things you should always know is that when you look at brain injuries, is that are they having expressions of what are called prime glial cells? And we went over this in the neuroinflammatory course. But prime glial cells are going to be expressed when a subtle inflammatory response causes an exaggerated response. So an exposure to milk, for some people, may cause bloating, but for people that have prime glial cells, that exposure to milk may cause severe depression. Okay? It may impact their dopaminergic pathway specifically, and they may not have the ability to initiate or follow through with anything. For some other people, that milk can impact their catecholamine pathways, and they lose all focus and attention and concentration. For some, it's all of the above. So there's going to be some uniquenesses and differences with individual responses. So you could have someone, for example, that has an exaggerated response to an inflammatory trigger, which may indicate prime glial cells from past brain injury, but then their neurochemical imbalance expressions could be totally different. One can have serotonin imbalances, one can have dopamine imbalance, one can have both. So there's kind of this overlap that's constantly taking place with these mood disorders. And there are lots of people that have these, especially when people get older, is these vascular injuries. Your key clinical clue, someone is having a vascular injury, is acute onset of symptoms. If someone says to you, I woke up, my mom was under stress, or my mom just woke up one morning and she had really severe anxiety at that point and never really responded. And then also we start to notice that she had restless leg. That could have been a silent stroke. Anytime you hear acute onset of symptoms, you have to think about microvascular disease. So anytime something suddenly comes on, like a mood disorder, like massive depression all of a sudden, or massive anxiety all of a sudden, you've got to think of the possibility of stroke. Anytime you hear immediate onset of a mood disorder or neurological symptom, you're always thinking about infection or vascular injury. So as people get older, especially those that are diabetic or hypertensive or smokers, they have this potential to have these little blood vessels rupture. They don't get massive strokes where they get into the posturing patterns and so forth, these little tiny strokes. They get acute onset of mood disorders. Or another key feature of vascular injuries is what they call stepwise deficits. They get worse, and all of a sudden they're fine, they stabilize, then all of a sudden they get worse, all of a sudden they get worse, and all of a sudden they get worse. And those are associated with microvascular disease. So these are very common in mood disorder pathways, okay? And the other key thing we talked about in this course is really knowing when a situation is primarily psychological, that really needs to be supported through different venues, whether they need to be referred out or not, or whether they're primarily psychological, but you really want to support their health physiology. Now, the only thing I can tell you about that is it's how you feel. Sometimes you just get a bad feel working with some patient. Their way they act, the way they blame. It's not uncommon for many patients with mood disorders to blame everyone for everything. If you see in their history they're blaming everyone for everything, you're going to get blamed for everything. Okay, and that's another red flag. So when you see psychological support that's needed and there's all those issues, you just may get the feeling to your workup that they're not the right person for you. And maybe you could have done some things working with them in a functional medicine approach, but you also have to consider, do you really want to work with them? One of the worst things you can do, as we talk about mood disorders, is bring people that can completely create an unhealthy environment for you. And if a patient is at some point where they have psychological issues, where they're made bad choices in life, bad things are happening in their life, they have different stressors in their life, and they're lashing out on you and your staff, there's not going to be much you can do with a functional medicine approach with them anyways. It's better not to just have them in your office at all. So that's really, really important. Figuring the right patient, the right person to bring into your office is really, really critical. And the other key criteria is when there is some psychological involvement is, are they okay? Are they at peace with, you understand, like you have these physiological things, that we can't get your blood sugar under control, we can't get your sleep under control, we can't get your leaky gut under control, because you have so much stressor, psychological stress that's happening in your life. We can try to support those pathways, so we're not expecting major cure. We just want to see if we can improve your function. We can experiment and see what things you respond to or not respond to. And that's really the primary goal. And our workups aren't going to be there to expect a treatment that's going to be successful, but really applications to improve your function. And if they get it, you can have a very healthy relationship and really help them. If they don't really get that, you can really create a very unhealthy environment for your office. And then whether the case is manageable, meaning that you can address and identify their mood disorder, that's what you ideally want. Or whether it's unmanageable, like some people just have brain injury. You don't know what their potential recovery is. Some people have early signs of neurodegeneration. Despite all your best efforts and despite all your best applications, they may just continue to suffer and go downhill. So those are the other things that you want to be aware of when you're looking at mood disorders. So let's go back here to the very first example. So if you have a 45-year-old woman with chronic depression diagnosed with major depressive disorder since age 40, she's not responding to antidepressants. No kidding. Because first of all, they don't work long-term. Their effect size has been very limited, and more than likely, she probably has all the things that current research, contemporary research has shown. She has most likely neuroinflammation. She probably has mitochondrial dysfunction. She has inability for synaptic plasticity. Her brain's not healthy. Wouldn't it be surprising to see that she may have early signs of mild cognitive impairment and early signs of dementia with her? So those are all the things that you may want to think about with someone at her age scenario. So unless she gets a complete individualized and personalized workup, she may not have any chance in the healthcare system, right? And then you look at a person like this, 30-year-old woman with episodes of anxiety that are unpredictable and debilitating. What's the cause of her anxiety pathways? Now, you may not know how to differentially diagnose that yet, but we're going to go into the neurology of anxiety disorders and talk about all the things that impact the amygdala, okay? But a very simple way of thinking about this is if someone has anxiety, that means that pathways that activate the amygdala are firing too much, or the pathways that should inhibit the amygdala are not firing enough. And then what are the different variables that can cause those mechanisms? And until that individualized mechanism and approach is addressed, she's not going to be able to function. And then when you see these scenarios where someone can't motivate, can't finish tasks, that's completely frontal. It's a prefrontal cortex, and that's dopamine. It's that ventral ascending dopaminergic system. So what's causing his dopamine frontal lobe pathways to not work? What are the underlying mechanisms? So we'll go into how dopamine is made, how it's synthesized, how it's cleared from the body. So sometimes knowing which neurotransmitter pathways are not working is very helpful for us for the diagnosis and some of our treatment approaches. And it's really important to know that when you see these patients that have mood disorders, that it's going to dramatically impact their life, especially at certain age groups. Like a 17-year-old who has episodes of depression and anxiety and can't develop friends during high school. Like high school is such a significant socially development period of someone's life. And if they just can't function at that phase, it's going to impact them for the rest of their life. So figuring out why they have anxiety, not just blaming on simple things, is really, really critical. And then also depression, right? And depression, everyone blames teenagers for depression being hormonal. It may not be hormonal at all. And I would tell you most of the cases it's not. It's other things. And it's usually blood sugar dysregulation, inflammation, combination of those things put together, even underlying things like autoimmunity that can be a factor that's there, and undiagnosed Hashimoto's. So those are the things that we want to cover. So hopefully you kind of see where we're heading. We're going into these mood disorders. We're not going to be going into individual protocols. What's really important for us is to get into the pathophysiology of mood disorders. The next two lectures, where we go into the neurology, neurochemistry, and neuroendocrine immunology of mood disorders. And then the following lecture, we go into the web of mood disorders. We'll start reviewing all the literature, how all these things actually work, what actually causes anxiety, what actually causes depressive disorders, and what all the different variables that activate these areas of dysfunction. Thank you for your attention.